program and how it will impact your 2018 payments. Also, some key points for 2016 reporting and being prepared, and what you need to be doing to prepare for your successful attestation, and what's coming next. A lot of people think meaningful use is gone, so we're going to talk about that and what it actually transitions into. So the first thing I want to talk about is penalties. So the 2016 reporting will affect your 2018 Medicare fee-for-service payment. The last year to begin participation and receive an incentive payment was 2014. So really what you're doing this year is really just attesting to avoid any future penalties. The Medicaid program, however, you can still attest this year and receive incentive payment. So if you are looking to attest for Medicaid, 2016 is the last year that you can begin and receive an incentive payment for Medicaid. Negative payment adjustments for those who do not demonstrate meaningful use began in 2015, which means if you did not attest in 2015, you're looking for a penalty in the year of 2017 because everything is 2 years behind. Now, of course, if you did file for a hardship exemption in 2015, then you would be exempt from any penalty within 2017. So for meaningful use, the first negative payment adjustment began, again, when you were collecting data in 2015. And then from there, it's going to increase. It would increase on annually by 1%. If you never have participated in meaningful use, you are looking at a negative 4% payment adjustment in 2018. So if you do not attest this year and you have not attested previously, you are looking to get a 4% penalty on your Medicare Part B fee for service in 2018. Now, one of the things that people forget about is there are additional payments wrapped in with that. So, for example, if you are not participating in the PQRS, there is a negative 2% penalty for not participating in PQRS. In addition to that, there is a third program called Value-Based Modifier Program, and depending on your practice size and depending on how well you do on your quality metrics, you could also face a 2 to 4% penalty. So overall, if you don't participate in any of these programs, you could be looking at a potential of up to a 10% penalty in 2018. So CMS at the beginning of the year said that if you were a returning participant, you were going to be expected to attest for a full year. And if you are a first-time participant, that you could do a minimum of 90 consecutive days. They did pass the ruling at the beginning of November that regardless of what stage you are reporting in, that all you will have to do is 90 continuous days. So my slide's a little bit off-dated here. So in November, they did pass the ruling. So regardless of whether you're a returning participant or a first-time participant, you only have to attest for a 90-day period. So if you have not started and you were thinking, well, I had to do a full year, so it's too late, you do have time because you could start that attestation period for October 1 and take that from October 1 to 12/29 for your 90 days. So you do still have time to make it up if you originally thought you weren't going to make it. So in 2016, there are 10 objectives. The first objective is your protective health information, which a lot of us call it the security risk analysis. And that's strictly a yes or no question. Did you perform it or did you not perform it? The second one is clinical decision support ruling. This one does have 2 measures within it. The first part of that objective is implementing 5 clinical decision support rules, and they do want you to have that related to 4 or more of the CQMs that you'll be attesting to. There is an exception to that, and that is that if you cannot find 5 decision support rules that relate to specialty-specific CQMs, then you can claim exemption on that. You still have to do the rules, but you don't have to match them up to 4 CQMs. The second part of that measure is making sure that you've enabled and implemented functionality for drug-drug and drug allergy interaction checks. Those two things cannot be part of Measure 1. So for your 5 clinical decision support rules, you cannot tie in drug, and drug allergy. You can, however, tie in geriatric precautions, pediatric precautions. You just cannot do drug, and drug allergy. The third item is your computerized provider entry. And again, this has 3 measures within it. The first measure is for medication orders, the second measure is for laboratory orders, and the third measure is for radiology orders. This one is attested to using a denominator and numerator. You can claim exclusions on these measures. It's based on the amount of prescriptions that you write, the amount of laboratory orders that you write, and the amount of radiology orders that you write. If you have ancillary staff creating those orders, you just want to make sure that in your system they are marked as a credentialed staff member. If you run your reports and you are failing these measures, you want to go in and look at the people that are writing the orders and make sure that they are marked as credentialing. If you backdate that credentialing, so for example, if you had an employee that started in 2014 and they just did not get marked as credentialed, if you backdate that date to when they started that they are credentialed, it will catch up on those orders. So just because they've written the orders and it's not recognized them currently as credentialed, if you put the correct date in there, it will update the percentage on that for you. Number 4 is electronic prescribing. This is a numerator and denominator. There is an exclusion attached to that. If you're a provider that writes less than 100 prescriptions in your attestation period, you can claim exclusion on that. Number 5 is your health information exchange. This is doing your referrals electronically as well as providing that referral with a summary of care, which sometimes you hear it called a CCDA document. There is an exclusion to that as well. If you refer out less than 100 times during your attestation period, you can claim an exemption on that as well. Number 6 is your patient education. That is a numerator denominator, and that's a very low percentage. It's 10% of your patients reporting in your period, in your attestation period. Number 7 is your medication reconciliation. This is a numerator and denominator. Number 8 is related to your patient portal, and this one means that your patients either view, download, or transmit to a third party their HIE information. This one does have 2 measures associated with it. The first one is related to providing the patients the access. So if you have a patient and they're enrolled in the patient portal, you would meet that measure. You're just simply saying that within 48 hours of the patient being seen, they did have access to go onto a patient portal and review their records electronically. The second message is that at least one patient, only one patient, it's not a percentage. For the full 90 days that you're reporting, you only have to have one patient that actually goes into the portal, views, downloads, or transmits their information. So it's just one patient, not a high percentage. That's all you have to show is one patient per provider. Number 9 is also related to the patient portal, and that is your secure messaging. Again, this one is just simply one patient. You have to show that one patient has sent or responded to a secure message via the patient portal. Now, some people get confused by this one and think that it's enough for the physician to send the patient a message. It has to be the patient either responding to that message or initiating the message. So it has to come from the patient's side. The physician or your staff can actually initiate a question and send that over to the patient, and then they can answer it. That would meet that particular measure. But just sending something to them does not meet the measure. And then the last objective is your public health reporting. So measure 1 is the immunization registry. You can claim an exclusion to that if you do not provide immunization. It is suggested that if you do not provide immunization, that for your immunization binder that you do have a statement in there from your provider stating that he or she is claiming exemption and they do not provide immunization. The second part of that is syndromic surveillance. You can claim exclusion on that if you do not live in an area that provides reporting for that. And then Measure 3 is a specialized registry. Now, some people get confused with Measure 10 because it does have 3, and you are able to claim exclusion on 1 and 2. If you claim exclusion on 1 and 2, that means for Measure 3, you do have to show 2 specialized registries. So make sure that you understand that in the public health reporting that they are looking for you to show that you have 2 registries, regardless of whether it's immunization and specialized, or if you're claiming exemption on Measure 1 and 2, then you need 2 for Measure 3, which is your specialized registry. There are some caveats to this, and that is that if you do not have your registry full on, if you show that you have registered and you're waiting for an invite or you're waiting for the final install, as long as you can show that you have that you are on the right path to that. So you want to make sure that you have at least acquired something, that you're in, that you have an agreement and you have a registration go in the process. And make sure that you save everything that's related to that. If it's emails back and forth that say, hey, thank you for the registration, you know, we have to work on our side to get you going. Make sure you save all of that for your meaningful use binder so that you have proof that you have been actively working to acquire that registry. The clinical quality measures, you do have to still select 9 measures that cover 3 of the 6 domains, and I have them listed here. It's patient and family engagement, patient safety, population health, efficient use of healthcare resources, clinical process effectiveness, and care coordination. So you do have to report on those. There are no thresholds for the CQM, so you can report 0. It's not really something that is advisable. You want to try to report to show that you you chose quality measures that you're actually capable of getting a positive numerator on. So you do want to be careful with that because you want to try to move into next year into the MIPS reporting with some good quality measures under your belt there. So the attestation deadline is going to be February 28th of 2017. So for the calendar year of 2016, whatever 90 days that you choose and you satisfy all the program requirements, in order to avoid the payment adjustment, you have to successfully attest by February 28th of 2017. And sometimes, it takes a little bit of time for CMS to get the website up. So they may say they're going to have it ready by the 2nd week of January, and it might end up being, the 2nd week of February, and then they push that date back. But for now, it is set at February 28th. So one of the things that I talk to a lot of people about right now is, making sure that you're prepared. Don't wait until the last minute to do your audit binder. Make sure that you've got everything going because something is going to pop up and you're going to, maybe you didn't think about and, you're rushing to get that done. So what I would do right now to prepare for a successful attestation, I would confirm what stage your provider is in. At this point, it really doesn't make a lot of difference because CMS has changed the guideline to 90-day participation, but still, are they a returning participant or are they a first-time participant? Check your provider's registration status. Do you have the correct login information? Verify that their email address is correct or the administration's email address is correct so that you get the appropriate notifications from CMS as you move through the process. If you're lucky enough to have attested prior and you are still in a incentive payment stage, make sure that your payment information is correct so that, the payment comes to the right facility. Does your provider have a surrogate user and is the login information up to date? So those are all things that you need to be looking at now so that you're not trying to get login information at the last minute. Verify that your EHR vendor is certified and that your software meets the certification requirements for 2016. Go ahead and go out there and get your certification number. Download your PDF certification file. Verify your reporting tools are in place and working properly. If you have not already done so, you should be out there right now running your baseline report. Figure out, where you are with your objectives. So that if you have a patient, if you have a provider, for example, that is at 8% on patient education, and it has to be 10%, don't wait until the last week to say, oh my gosh, you're at 8%, we got to get 2% in the next week, because that's probably not going to happen. But if you look at those items now, you have time to course correct and get that going. Same thing with CQMs. You still have time. If you are only meeting 6, go out there and figure out what other 3 would be easy enough for you to go ahead and get some participation on. So get that benchmark reporting done as soon as possible. Figure out where your providers are at and what you need to do to course correct that. Also, make sure you complete your meaningful use audit binder. You want to make sure that your data and screenshots reflect your reporting period. You need to make sure that if you have to do file maintenance settings to show that you had something turned on, or universal preferences to show that you have your drug information turned on, make sure your screenshots include a date on your PC to show what day you took those screenshots. That clearly identifies that you had that information up and running in the time frame that you're attesting to. So meaningful use is not dead. It's just simply going to take a different turn. So what's next for meaningful use? So beginning in 2017, providers are going to be switched over to the MIPS program. So there's a lot of conversation about MIPS and what it's going to be and what do we have to do. So people are thinking that meaningful use, all these things that they're doing for meaningful use, we won't have to continue to do. So that's not actually correct. They're actually taking meaningful use and they're just renaming it to advancing care information. So MIPS takes 4 categories. So I put meaningful use, which will now be called advancing care information. Value-based modifier will be replaced by something called cost, and PQRS and figure CQMs on that as well. Will then be replaced by quality. So what you're doing now for meaningful use, if you've got a good momentum going for that, if you move into 2017 with the mindset that you just have to keep on going with what you're doing, then you're probably going to be successful at the MIPS. So I just kind of wanted to mention that for the meaningful use proposed name advancing care information, there are 5 base measures that are included, and these are already things that you're doing. Security risk analysis, e-prescribing, patient portal, patient provider access, sending a summary of care, or requesting and accepting a summary of care. So those are things that you should already be doing. One that might be out of your comfort zone is requesting and accepting a summary of care. So that one might be a little bit new, but the other 4 are things that you're already doing for meaningful use now. So you just want to keep pushing that along. Don't think that next year you don't have to do it. And then in addition to that, there are a lot of the items that you're doing that will be extra points. So for example, patient education. Yes, you could stop doing patient education and tracking it. However, in the MIPS world, if you continue to do patient education, then you get additional points and incentive for doing that. So some of these things that you're doing for meaningful use, even though they're not on the base of the MIPS, they still get you additional points. So you want to continue to do what you're doing to be successful for MIPS. So again, improve on these programs now. In order to potentially increase your revenue now and help prepare yourself, you should be reporting data on quality measures through the physician quality reporting system. Know what your quality and resource use report is. Use your EHR to attest to meaningful use. If your practice is not currently doing chronic care management services, then you may want to think about preparing to do that for next year as well. That's something that a lot of people aren't familiar with, so it is something that you could dive into and kind of start seeing if that meets your practice. So it's just kind of like a thing that says, what we're doing today, is it putting your practice headed in the right direction? So all of those are things that you want to look at for the future. So again, the feature of meaningful use is expected to change under the MACRA and MIPS, but it's not going away. The pending changes will affect Medicare MU program, but not necessarily the Medicaid MU program. The Medicaid MU program is currently scheduled to end in 2021. So I would expect that the current objectives and measures for the way that we're doing it now will probably continue on with the Medicaid MU program, but the Medicare does shift over to the MIPS portion of it. So the next thing that we want to talk about is what's called a state of the practice review. So I'm going to go ahead and turn this over to Jonathan Shivers, and he's going to talk a little bit about how to examine the state of your practice and determine, are you ready for meaningful use for 2016? Are you ready to move forward into 2017? So we're going to go ahead and let Jonathan talk to you about that a little bit.
Thanks, Rhonda. So Rhonda has just compiled a lot of information to about 20 minutes. Thank you for doing that. And before we open this up for questions, I want to walk through the state of the practice just in one slide, two slides with you rather here. The first thing is this is complimentary. This is something that we offer all of our clients monthly, and we have now expanded it to we run it for all practices now that request it. It doesn't take much time for us to run for you, and whichever system you happen to be running on the PM or EHR side, it's still going to be able to run for you. So it's something that we can make agnostic. If you could forward me to the next slide, Rhonda. So the KPIs that we pull on this report, you can see starting on the left-hand side, a lot of them are process-related and billing-related. So where are your denials? Where are they coming from? Who are the major offenders? What's your self-pay look like? What's your payer breakdown look like as far as your reimbursement and AR is concerned? Then on the right-hand side, we start to look at things like template usage. Are you customizing things that really make sense for your workflow that are most efficient? Where do you stand today with MIPS bonuses or with your MIPS penalty? What is the actual dollar amount you have to gain or to lose each year? And the last one you see there, what unspecified ICD-10 codes are you still using? We did a webinar last week about ICD-10 codes. If you're still using unspecified codes, you're going to start getting denials for those after this past October. So we're also able to see which codes are you still billing that you're going to be receiving denials for. So this report captures a lot of information, and it's something, again, we run monthly for our clients. If you would like us to run this for you, again, there is no charge. We would be more than happy to run it for you and shoot it over to you so you can see a quick snapshot of the health of your practice on both the clinical and the billing side, and to make sure you have the right steps in place for MIPS coming up. So I'd like to open this up to questions for Rhonda. I'm going to unmute everyone's line here. And does anybody, I believe that's everyone, does anyone have any questions for Rhonda? Oh, don't be shy. I know someone's got something for her. Come on, don't let her off easy. No questions. Okay. Well, Rhonda, you must have aced it. That's perfect. Well, okay. I wanted to give everyone our contact information. If you do have any questions for us, or would like to hear about how Rhonda puts together packages to get folks through meaningful use and handle their measure selection, their monitoring, their reporting, their attestation, and their audit binders. We do that for our clients as well. We would love for you to reach out to us. You can see us on we relaunched our website at www.careoptimize.com, and you can also check us out on LinkedIn as well. Rhonda, anything you would like to add?
I don't think so. I think, like I said, just, if you thought you weren't going to be able to make it because it was a full year, I would just reconsider and realize that you do have time. There's 6 weeks left to course correct, and I'm doing that with some people now, and I think you can still be successful.
Wonderful. Well, Rhonda, thank you so much, everyone.
I appreciate it.
Thanks very much, everyone. Y'all have a great weekend.
Bye.